Hi, everybody. I'm not sure we're showing up on Instagram, so let's just double check that. Oh, there we go. We're up and live now. Terrific. Well, welcome back to Fertility Fact or Fiction. It is great to have you all here. We had a little interesting thing happen to us tonight where our social media director, Tarek Ibrahim, unfortunately ended up having a medical emergency, and so he's not with us tonight. So tonight you just get me and our lovely friend Rebecca, who is going to help us out through this. I think we're off camera a little bit there on Instagram. I'm not sure why, so maybe we can center that somehow. Rebecca, if there's a way to make that work out better, perhaps we could leave that in your very capable hands, because I think I'm sort of halfway off the screen at the moment. I'm not sure why, or maybe we need to do this. Nope. Well, we'll do our best, guys. Sorry about that. I think you're going to get like kind of a halfway view of me. So I'm not sure why that is happening, or if it's a problem with the camera. Okay, that's going to look ridiculous. Well, my apologies. I guess we are having some issues with the camera. It might be reasonable if we try moving over sideways a little bit. Let me see if that helps. Just give us 1 minute there. I'll see if that pulls us over. I'll rotate my camera to the right. Let's see if that allows a bit. Looks fine on Facebook. Well, there we go. I think we're moving across on Instagram there, and it seems to be working eventually. Okay, guys. So hopefully that's about as good as we're going to get it. So hopefully that's okay. I'll just tilt it down a bit, and we to go. So as I mentioned, my apologies for the technical issues. We are live. And Tarek is not able to join us tonight because of a medical problem. So sorry about that. So we'll see if we can get that to just tilt over somehow. That looks wild. Okay, so if you're watching us on Instagram, you may want to switch over to YouTube because it's clear there, and so is Facebook. And I apologize on Instagram. It's a little bit crazy right now. So the topic we're going to have for you guys tonight, maybe it needs to go this way actually, is on fertility and cancer. So we're actually going to be discussing whether or not your fertility treatments impact your chances of having cancer. And we're going to see if that impacts things. So the reality is this is something that has been debated for a very, very long time in the medical literature. There has been an enormous amount of back and forth as to whether or not this actually does or does not have an impact, with some people saying that it does have a significant impact and others saying that it has no impact whatsoever at all. Many studies, a lot has gone into this. In fact, the authors of this study found 128 articles that reviewed this topic. And specifically, they were looking at the risks of cancer in the individual woman doing the IVF procedure. And so they were isolating it to risks of breast cancer, endometrial cancer, ovarian cancer, and cervical cancer. And so they were really evaluating that, trying to figure out which one of these is most going to impact or be impacted by your fertility treatment. And they broke it down into oral medications like clomiphene, and then the menopausal gonadotropins. And they were mostly looking at doing IVF procedures to see to what extent that actually impacts everything. So when they carried on through this study, They started with 128 articles. And from the 128 articles, they narrowed it down to just under 80. And then they had to exclude several more, and then they got it down to 53, I believe. And from the 53, they finally narrowed it down to 29 studies that were included to capture all of the data that they felt was rigorous enough to meet their criteria. So when they did all of this, they ended up with an enormous database worth of patients. So from the 19 studies, there were 7,769,980 women. So obviously like a mega study, right? We're talking about absolutely huge numbers of people, and that's obviously really critical and something that we want to definitely evaluate. When they looked at the people in the fertility treatment group, 301,199 of them actually had fertility treatment. And when they looked in the group that did not have fertility treatment, it was 7,468,781 that were in the fertility treatment group that did not actually get any therapy. So their comparison group was over 7.4 million, and the group that actually had the treatment was 301,199. So let's get to the data right away, because I know everybody's very, very curious about this. And I apologize for the various views that you're all getting here. We're floating on 4 different platforms on a new camera because my amazing expert Tarek is currently ill. But we will send our prayers out to Tarek for sure. Looking at the overall incidence of cancer in the group, meaning the chance that you would have breast, endometrial, cervical, or ovarian, there was absolutely no statistically significant increase in the risk. How high or low was it? So the odds ratio was 0.95, which actually indicates a decrease, but it wasn't statistically significant, which just means there's no association. So overall, they are not demonstrating an association between any of the 4 cancers and the chances that you've had fertility therapy. When they looked at individual outcomes, breast included 19 studies, and in those 19 studies, they just barely missed significance for being a statistically significant decrease in success. So the odds ratio was 0.86. And from that, the confidence limits was 0.73 to 1.01. So if it had been just under the 1 level, it would have been statistically significant, indicating a decrease overall. When they looked at ovarian, 1.19, but again, it crossed 1, so no significance. When they looked at endometrial, no significance. When they looked at cervical cancer, interesting, there was a statistically significant 32% decrease, but it just met the criteria for being significant, which was 0.46 to 0.99 for that confidence limit. So questionable, and actually it doesn't make a ton of sense because cervical cancer is caused by a virus, but nevertheless, patients did look at that in this, or the authors did look at that in this study, and in doing so saw that there was a statistically significant decrease. So then the authors broke it down by treatment categories. So this is really interesting stuff and a little bit concerning because it brings up some old data that none of us really paid much attention to. So when they looked at breast in relation to Clomid use, there was no statistically significant association. Doesn't increase, doesn't decrease. It's a neutral impact. So if you're taking Clomid, which we really don't use too much anymore, there's no change in your breast cancer risk. When they looked at ovarian cancer risk, there was actually a significant increase, 40% increase in your risk of ovarian cancer. Why? The authors say they don't know. They think it has something to do with making multiple follicles and then the IVF procedure mixed in together. But the reality is, and I'll show you in a minute, that when they looked at this from the standpoint of injectable medications, there was no issue with ovarian cancer. So it doesn't make sense that it would be there for Clomid, based on those criteria, but then not be there for the shots, because you make even more eggs with the shots typically than you do with the Clomid. Years and years and years ago, there was a study that showed that if you did Clomid for more than 12 cycles, you did have an increased risk of ovarian cancer. And so a lot of us shied away from doing it when we had that many. However, the reality in this particular situation is, this is saying even with any use of Clomid, not necessarily 12, you are increasing your risk. So is this the kind of death knell of Clomid? I don't think so, but we do need to caution patients that maybe there's a slight increase in risk. Endometrial cancer with Clomid, no increased risk. And when they looked overall at the risk of breast, ovarian, or endometrial, there was actually a statistically significant risk, in large part carried by the ovarian. But between the contributions of all of them, it kind of nudged it into overall increasing the risk. And that risk was 23% higher. Now, we rarely use Clomid anymore. For our PCOs, we're turning directly to letrozole. And for our patients that want to do Clomid instead of injectables because of cost, and they just want to make a few more eggs, I really don't feel that the risk is substantial in that population group. But we do need to be cautious with this, and the data does need to be looked at further. And they say that in this study as well, that it's really critical that we evaluate further, get some more data. Problem with that is we're not using Clomid as much anymore, so it'll probably take quite a bit of time before we get to the point where we'll have that kind of data. They then looked at the relationship in relation to secondary outcomes with human menopausal gonadotropins. So these are the FSH shots, but the urinary derived ones, not the recombinant ones. And they looked at breast cancer, and there's actually a huge reduction in the risk of breast cancer when you were doing the shots, a 56% decrease. Now, the authors argue in the study that it may have something to do with the brief period of time you're exposed, and maybe it's stimulating something. But I think the reality is that it's actually much more related to the fact that many of these women become pregnant, they have children and breastfeed, and that by itself is the single largest reduction in any cancer risk that you can actually get in general with gynecologic cancers. And breast cancer. So I think that has a lot more to do with it than anything else. They did mention that when they analyzed this further, looking at the extent to which confounding variables, age, BMI, smoking status, and so on, affected it, the relationship was less strong, so that it didn't look like it was as much of a reduction in risk of breast cancer, but definitely not an increase in risk. So in that regard, it's safe. They also looked at the patients where you combine Clomid with the injectables. They said no risk for breast or endometrial cancer. And then they also looked at just the injectables, not the human menopausal gonadotropins, but the recombinants and the human menopausal. And in all three of breast, ovary, and endometrial, there was no increase in risk in any of the three of those, and no decrease either. So really, they're saying the shots don't seem to help overall. Although if you use the urinary derived one, so that would be like Menopure, for example, that the breast cancer did seem to be reduced, at least in this population. Because of that Clomid concern, they broke down the Clomid into a further data set, and they really delved deep into that. So when they looked at Clomid and breast cancer, they showed that there was no statistically significant relationship, again, between the use of Clomid and breast cancer. So no specific effect. A slight kind of trend towards an increase, but not statistically significant. Some of the studies definitely showed an increase. Realistically, there was only one that was clear on the increase side. There were none that showed a significant decrease, and several that kind of crossed that line of significance. When they looked at Clomid and ovarian cancer, every single study but one showed no significance independently. But when they compiled them all together, there were enough trends in favor of a significance that it actually carried it through to being significant. So again, the old adage for all of this is crap in, crap out when you're doing a meta-analysis, which means if the data going into it is not very strong, you can't necessarily trust it to give you a good answer on the end of it. So how valid is that data? We really don't know. When they looked at endometrial cancer and clomiphene, again, they showed no statistically significant increase or decrease, although it does trend again towards an increase. And this population, of course, is the population that almost always is the PCO population. And because they're the PCO population, there is no doubt whatsoever that those patients are at significantly higher risk than others, because anovulation or chronic oligoovulation, where you're not ovulating regularly, significantly increases your risk of having endometrial cancer. And I meet women at least a few times a day throughout my practice who have not been told that they must have regular cycles. And we repeat it, I would say, virtually every week on Fertility Fact or Fiction. So it's super, super critical for you guys to make sure that you are getting checked in that regard, to make sure that you are ovulating regularly. So is it a fact or a fiction that fertility treatments are associated with gynecologic or breast cancers? It is a fiction overall. There does not appear overall to be a significant increase or decrease in risk. If you break it down into its component parts, Clomid may increase your risks of ovarian cancer, whereas the human menopausal gonadotropins may decrease your risks of breast cancer. So overall, the patients going through IVF have no increased risk based on this study, because typically in an IVF cycle, you're not using Clomid, you're using injectables. And so it's not a risk for anything in that situation. For the patients that are going through Clomid, talk to your physician. You probably have a much better option in turning towards using something like Retrieval, or maybe a very low dose of the gonadotropins, as long as they're affordable for you. So amazing topic. I'm so happy that they've come out with this study. This is brand new from February 2021. It's in Human Reproduction. The authors are Jennifer Francis Barcroft, and these folks were from Imperial College London, which is a fantastic university in the UK. It's a great article. It's complicated because the stats are quite sophisticated. And again, you have to account for the data going in and out of this. But overall, this is a great study showing that there was no significant increase overall in your cancer risks. So thank you so much for joining us for that part of the show. We're going to turn to taking your questions live now. There are a whole slew of people that have been asking, and I'm going to have to figure out how we can scroll up and down through our questions. That might be a tough thing to do. So, okay. Hi, Dr. Victory. I have only my right fallopian tube. I have 2 ovaries. If my dominant follicle is on my left ovary and I trigger, are my chances for conception slimmer? They are probably slimmer, but there is still a chance. Somehow, and no one's quite figured it out yet, the opposite tube can kind of reach over and grab the egg from that ovary. So if you have a right tube and a left follicle, it is possible for the right tube to reach over and grab it. Probably a reduced chance, but it is possible. So yeah, it's definitely something that can happen. And we have definitely seen that before in our practice, and it's readily known and widely published before in case reports and others. I'm assuming that, Rebecca, you popped up that question. I don't think I did, but let's see how we get rid of that. Yeah, that's Rebecca. Okay, I'll take an Instagram question as well. So let me see here. We've got going for medicated transfer cycle baseline appointment tomorrow. My cycle is much lighter than usual. Could this be problematic for transfer cycle start? So that's an amazing question. And the answer is no, not at all, because we're going to typically give you some hormones, especially in a medicated transfer cycle. You're agreeing to take some hormones to thicken your lining. So you've got ample amount of time to use estrogen to thicken your lining, then start your progesterone. So having a thin lining at the start is typical because usually you'll start the meds after you've had a period. So that's quite common and not an issue at all. I can do another one from Instagram, and Rebecca, you can always pop up a question when you want to. Here we go. Hello, Dr. Victory. I froze my eggs in multiple cycles. The first couple of cycles, most of my eggs were immature because I was doing the Lupron flare protocol. After switching to antagonists, I did much better, but my eggs were about half immature. This is from Kate. Rebecca, is there more to that question? And if not, I can certainly answer that. So the Lupron flare by itself does not create or not create mature follicles. It's just a stimulation protocol. The timing of your trigger is what determines if your follicle is mature or immature. So if you, for example, have follicles that are over 16 millimeters in a crosshatch diameter like that, then the likelihood is quite high that that follicle will be mature. If you have follicles that are not in the crosshatch pattern, or they're not 16 millimeters in diameter on the crosshatch pattern, then the likelihood is much, much lower that you would end up with mature follicles. So if you're triggering when you have 14s or 15s, that's too early. There are some rare patients where even where the follicle is bigger, 18, 19, 20, where we're quite sure it's mature, and then beyond 20, they start to get post-mature. There are some patients who still have immature follicles. And unfortunately, despite the fact that IVF costs so much, there are times where it takes us more than one try before we can actually get it right for you. So there are some instances where it's not quite perfect and we need to adjust for that. So yes, that is a possibility. Thanks, Beck. We can go to the next question on Instagram here. So let me pull that up. Oh, you've got one there. Hello, Dr. Victory and Rebecca. Vistory. My question is about adenomyosis. How to treat adeno? How should I change my daily diet or routine when experiencing adenomyosis? So for everybody to know, adenomyosis is like endometriosis. It's when the tissue in the uterus goes into the wall of the uterus. Very painful, very heavy bleeds, uncomfortable intercourse, and very tender in your uterus kind of all the time. And then it does, in theory, decrease your success rate. So diet-wise, Mediterranean diet, avoid meat, avoid processed foods, low cholesterol, low sugar, lots of antioxidant vitamins, and at the same time, nothing with hormones in it. So as much organic as you possibly can. From the standpoint of how to treat it, from a medical standpoint, there are good therapies. So Lupron is an agent that can treat this. There is Vizan, which may have some benefits for adenomyosis. There's Orilissa, which has benefits for adenomyosis. We had a great product before called Fibristol, but apparently it was doing some damage to the liver in certain people, so they pulled it off the market. So there are some medical therapies, there are some natural therapies. I always advocate for traditional Chinese medicine and a naturopath. So hopefully you can try some of those and see what kind of luck you get with that. Let me pull up another Instagram question, Beck, and we'll go from there. I just switched from Instagram to YouTube. YouTube looks much better. Good. I hope I'm not off to the side on YouTube. Beck, if I am, let me know. I don't know if you can check our YouTube channel because I've got the phone on or the camera on an angle just so I'm barely on the screen on Instagram. I'm measuring 1 day behind on my 7.5-week scan, even though we did IVF. Is this concerning? Heartbeat is 145. That is a fabulous question. So thank you for asking. And no question that we can definitely talk about that and give you very, very good reassuring information here. So ultrasound at 7 weeks in the hands of the best ultrasonographer in the universe will have about a 5-day margin of error, sometimes as high as a week. So 1 day off is actually absolutely meaningless. Nobody is that accurate. So you don't need to worry about that at all. It's completely reasonable to have a several day discrepancy between your dating, even with IVF, and your ultrasound measure. Your heartbeat is perfect. So congratulations, you are well on your way to being and staying pregnant. Let's take a Facebook question. Oh, there we go. What are your thoughts on immune protocol? My first FET failed with a Euploid embryo. My RE doesn't want to change protocol for FET2. I heard adding prednisone and Lovenox may help with inflammation. So the data on the immune protocols is not great. It very much depends on which patient population you explore in terms of, is this a patient population that is known to have an immune problem? Have they measured the cytokines, the helper cell levels? Have they done an endometrial biopsy? Have you done all of the necessary testing? Or are you just kind of randomly treating? So the best answer for this is from a fact or fiction we did several months ago, looking at the relationship between euploid embryo transfers with no additional adjunct treatments or tests whatsoever, and what the outcome was. And we talked about this last show as well. This is a study by Richard Scott, who's kind of the biggest guru in the world as far as I'm concerned for IVF. And they showed in their study that if you had 3 genetically normal embryos, or euploid embryos, like Jennifer is asking here, that the chances of success with no steroid, no heparin, nothing, was actually 95.2% if you just did the same thing every single time and transferred them back into the patient. So if you watch our embryo math video on YouTube, we actually account for that, and we talk about those percentages. And so you can kind of hope that if you have other euploid embryos without doing anything whatsoever, you have a good chance of success. Is everybody going to succeed? No, 4.8% will not succeed because it was only 95.2, and those patients may need additional therapy. If it's your one and only shot, I would recommend seeing someone who is a reproductive immunologist if you're worried and you have very limited numbers of embryos. So we work with Fred Zineku and Chloe Romaine of Tripod Fertility. Awesome people. They're my colleagues. I was just on the phone with Fred this evening, and they do a great job, and they can guide you and advise you on what to do. I think we're all using Fertilisys for our testing because it's a little bit cheaper, but none of this stuff is actually inexpensive. So there is like a cost-benefit ratio, and you really have to analyze when to jump into that. For me, the threshold is 2 euploid embryos. So if I've done 2 euploid embryo transfers and I am not successful, I want to start exploring why it's not successful. And at that point, I am willing to tell the patients to invest into that testing to figure out whether there is an immune problem or not. What can you do once you find out? Steroids, intralipids, heparin therapies, usually low molecular weight like Lovenox. You can talk to the naturopath, again, the traditional Chinese medicine specialist. Get your diet very controlled. Avoid everything that is oxidative, so smoking, drinking, drug use. Stress even can be reduced. And there are some other things that can be used as well, like subcutaneous IG therapy or IVIG therapy. So there's a whole host of opportunities and options to explore that can help you with this. So yeah, any of those would potentially work. Thanks, Beck. I'll take oh, you're putting them up faster than I can get to you. I'll take an Instagram next. So what is a good anti-androgen birth control? Oh, that's an excellent question. So there's 2 anti-androgen birth controls. One is called Yasmin, or Yaz now. So Yasmin is the higher dose and Yaz is the lower dose. And then there's Diane 35. They are both good anti-androgenic birth control pills. Keep in mind that Diane 35 is not actually registered for use as a birth control pill. It's actually designed for acne, but it's a perfectly good birth control pill, and I have family members on it. So it's completely reasonable to use. There is no best birth control for PCOS, but an anti-androgenic one is certainly not going to hurt. So that's a great question. I applaud you for asking that. And yeah, I would probably stick with Yaz or Diane 35. So either of those are good. Okay, Instagram. How much Inositol daily is recommended for PCOS? Any particular brand superior? So it depends on who you ask. Naturopaths have their likes and dislikes. I know that our naturopath, Dr. Jennifer Strong, she likes to use NFH. She loves their products, and they do have an inositol. We use Inosia from Yad as well. I personally don't know that there's a head-to-head comparison. In fact, I'm quite sure there isn't. So I think they all do a good job. Usually you want around 1,000 of inositol. So, and that's a combination of the D-Chiro and the Myo. So hopefully that's going to answer that question. Let's answer one from YouTube. Have an IUI coming up and supplements I should take alongside the prescription meds. So it depends on why you're having an IUI. We have a whole medication chart that I put in each patient's chart that breaks it down into endometriosis, PCOS, or just kind of normal patients. So if you're normal, you want your prenatal, vitamin D, iron, and the more antioxidants you take, the better. So melatonin is very good for fertility. We've proven that in another Fact or Fiction show about 1.5 years ago now. You want to take inositol if you have PCOS. You want to take NAC if you have PCOS. You want to take NAC and curcumin if you have endometriosis. The fish oils are probably beneficial. There's no really great studies on that, but there are some that suggest the benefit. And of course, coenzyme Q10 is quite ubiquitous and particularly good for women with PCOS. So it depends on what's wrong and why you're doing the IUI, but there are a bunch that can be done. What age should my daughter get her HPV vaccine? Do you recommend it at all? Chantel, great question. I love you guys, by the way. Thanks for all you do. So Chantel, the answer to that is they are typically vaccinating youth for HPV. Anywhere now as young as 8 and starting normally around 13. And they used to stop it at 26, but they're now extending that into adult years. Do I recommend it? 1,000,000,000% yes. There's literally no cases of complications from HPV vaccine. There was one poor soul that received the vaccine, went out partying on the beach all night, had a heart defect, was drinking, and had some kind of heart issue and unfortunately died. It had nothing to do with the vaccine whatsoever, and there are no other reported cases of anything like that. So HPV vaccine is amazing. Even if, like me, you're staunchly religious and don't believe in premarital sex and want your kids to not do it either, you have no idea what their partners are like or who they're being exposed to later in life. So this protects people from developing cancer. It is the best vaccine ever made. I would argue that it is, in some ways as potent or as valuable as having the HPV vaccine, or sorry, the coronavirus vaccines that are out now. So we have never in history been able to prevent a very common cancer by simply vaccinating people against it. And keep in mind that the virus that causes cervical cancer, vulvar cancer, vaginal cancer is carried by 80% of people. So that's a lot. Okay, Instagram. Hi, Dr. Victory. I'm about to start my IVF cycle and I'm on the birth control. However, I've been getting spotting the past few days. Is that normal? Yeah, it can be normal. And as long as you're not beginning to grow eggs, meaning you've broken through the birth control, it's perfectly safe and fine, and there's no worries with that whatsoever. Are all euploid embryos equal? I had a chemical pregnancy with a euploid day 6 5BB embryo and a failed transfer with a euploid day 7 5CB embryo. That is definitely an embryo issue. So if you watch our show from last week, we talked about day 5 versus day 6 embryos. So the day 5 embryos are much stronger than the day 6. So that's really important. And day 7 is definitely weaker. and a day 5 CB embryo is not a very strong embryo. In fact, that's one we wouldn't even keep, regardless of whether or not it was euploid. The chance of an embryo like that implanting and becoming a normal live birth would be very, very low, probably less than 10 or 15%. A day 6 5BB is actually a good embryo. Don't know why that wouldn't stick, but the day 6 is not as good as a day 5. I would argue it's worth taking a good look at you again, and this would be a case where maybe exploring the immune protocol, rechecking your infection status, doing the hidden C test from Fertility, loads of other tests and approaches, endometriosis check, laparoscopy, that kind of thing can be really beneficial. Okay, one more on Instagram. We're going kind of back and forth. Oh, my wife's watching. Hi, honey. Okay. Instagram, going for medicated transfer cycle. Oh no, we asked that one already. What are your thoughts on 5 weeks of birth control before IVF cycle if AMH is 38.5? As long as you're not over suppressed, 5 weeks of birth control with an AMH of 38.5 should have no detrimental side effects whatsoever. There was one study a long time ago where they suggested that you needed a minimum of 6 or your risk of having a miscarriage was higher, but it wasn't with frozen embryo transfers, it was with fresh. And your 38.5 for your AMH almost certainly will dictate doing a frozen embryo transfer, so I wouldn't worry about it too much. It should be okay. All right, Beck, you are on the ball. I may have to make you be here with us every time. We had a miscarriage at 7.5 weeks. Oh, I am so sorry. That's terrible. There was a strong heartbeat at ultrasound the previous week and growth was spot on. I can't see the, oh, maybe I can see the risk. But is it possible for a euploid embryo to develop a chromosomal abnormality later? Beck, remove the question for a second and I'll be able to see the rest of it. To develop chromosomal later in development, other reasons. You can put it back up. Thanks. That's a great question. It could be embryo factors. So the embryo may be energy inefficient. The placental portion, which has to supply the embryo with all its nutrients, may have not been high enough quality. There is the possibility that there is something wrong with the host. So in other words, if it's an infection in your uterus, if you have an immune abnormality, if there is a structural change where you have a septate uterus or severe arcuate, fibroids, polyps, any of those could be, possible causes of a problem. So I would restart the whole process again and recheck everything. And we do that fairly commonly to make sure everything is perfectly safe. Why would a doctor add femera to follistem and menopure to egg retrievals? What is percentage of euploid embryos at 44? And have you been successful with 44-year-old patients? Thanks. Bird Bash. Great name. So Bird Bash, the answer is the chance of a euploid embryo at 44 is probably around 10 to 15% that you would get a euploid embryo. If you go on our YouTube videos, Embryo Math, I think it's currently our fastest rising video. There's about 13,000 views this morning. There is a graph in that. It's a PowerPoint presentation where I'm kind of communicating at the same time. And you can see on the graph what your chances are. So you have to kind of extrapolate because it keeps going up. But at 44, you've got a very high chance of a aneuploid or abnormal embryo and a low chance of a normal one. Have we had success? Yes, but they are admittedly few and far between. Letrozole would be added because some people believe that it potentiates or assists with the egg production and will help you make more eggs than you otherwise would without it. So that's why that is in there. And I think I polished off Instagram. Instagram watchers, you're welcome to ask more if you need to. Okay, Beck, you're up. Thanks. Thoughts on transferring 2 PGS tested embryos at one time? 43, a few miscarriages. This service is amazing. You are very knowledgeable. Know that you are helping a lot of people. Prayers to you and your family. Well, thank you, Sarah. Sarah, that's very lovely of you to say. Okay, so that's a great question. I try very hard to talk my PGS tested patients out of doing a double embryo transfer. You probably have somewhere on the order of a greater than 70% chance of ending up with twins. What's the downside to twins? Okay, here we go. Preterm labor, premature rupture of membrane, miscarriage, stillbirth, high blood pressure, diabetes, abruption, hospitalization, God forbid, preterm delivery causing a whole host of other problems, meaning cerebral palsy, blindness, respiratory difficulties, feeding difficulties, short stature, reduced IQ. I mean, this list just keeps growing. Even if you're flawless and absolutely nothing happens to you, it's an 80% divorce rate. So we never encourage people to do it, with the one exception of patients that are genuinely older. They're 50, maybe kind of 48, 50, excuse me. And in that age group, there are social determinants of value or validity to trying to have two kids at the same time. Because just looking at the lifespan of the parents, you've got to factor in that the kids are going to be young adults starting their own lives when the patients are going to be needing, or the parents are going to be needing help. So I would, at 43, you're still young. I would encourage you to consider just doing one and not two. However, if you've had several miscarriages, before you do any embryo transfer, you need to figure out why. And never just do it without having an answer, or at least an attempt to get an answer. And by and large, there's always more testing that can be done. So don't give in too easily and just say, hey, I'm just going to go for it. Make sure that they're exploring what's wrong first. Great question. Thank you for asking that. Okay. Dr. V, going for IVF soon. I like Dr. V. That's cool. Should, I think that means my partner, get the COVID vaccine before treatment? Can it affect the sperm? We have no data that the COVID vaccine affects sperm. There is a study out now, actually two, which show that COVID infection temporarily impacts the sperm quality, but nothing on the vaccine. And in theory of how at least the Moderna and the Pfizer vaccines work, there is no evidence that it would impact sperm in any way whatsoever. So it's not a problem for your partner. However, women should not try to conceive within 2 months of the first shot, just because it is aggressively stimulating your immune system and you're where the embryo is going to implant, which is not a great idea. You don't want your immune system kind of in full activation mode when you're trying to get the embryo to implant, because they kind of have to cooperate. You don't want your immune system underactive or overactive. You want it balanced. Hi, Dr. Vic, or hey, Dr. Victory. What sort of mental health counseling resources do you have or suggest for couples struggling with infertility? The divorce rates for couples struggling, I'm sure, are very high. They are, and the marital stress levels are high. And we actually are in the process of preparing a video on sexual function and infertility, which also gets strained. And God knows, if you're not having a good sex life, it definitely can impact your relationship as well. We here built what I would argue is the most robust program anywhere. So we have our phenomenal social worker, Darcy. Darcy Thatchuk. So Darcy, if you're watching, hello, and God bless you for all you do for our patients. We have our online program, which is called Organic Conceptions, which we pay for, so all of you can get it for free, and I'm happy to offer it to anybody. So if you guys want it, email info@drvictory.com and we can set that up for you. And that's a great program that Darcy actually works on as well. We've got our wonderful psychologist, Brenda Davies. We work with some psychologists in Toronto. We have our naturopath, Jennifer Strong, who's amazing at stress reduction. Mary Wong in Toronto from the traditional Chinese medicine side. And then, of course, we take great pains to make sure that we are there for our patients. So half the population of Windsor and elsewhere has my cell phone and is texting or calling me to ask me questions or to reach out because they need help in an emergency or an urgency. Except for the odd patient that texts at 3 in the morning to ask if they can have sex. So by and large, we have a very, very, very robust program. And I make sure we tell everybody our catchphrase, which is no one walks alone at VRC, meaning we're there to hold your hands. We're there to carry you through this. And when I say we, I mean our whole team. We even have a nutritionist. We work with an addiction specialist. We really take this as a holistic approach. I don't believe in just pounding people full of medications and then saying, oh, sorry, it didn't work. Or congratulations, see you later. We really want to treat you like you're a family member, and I would go above and beyond for any member of my own family. So why wouldn't I do it for you guys? So we really built this incredibly, incredibly robust program. Thanks for asking that, Nicole. That's a huge opportunity for us to pump ourselves. Beck, let me ask a question from Instagram. Okay, so is birth control always necessary for an IVF cycle? Why is it used? It lines up your follicles so that ideally more of them grow at the same rate, meaning you'll get more that are mature. It's not good for everybody. Some women get over-suppressed, especially if you're older. We're shying away from using it for that group now. We focus more on using it just for patients that are like under 38. Over 38, we tend not to use it 38, 39. But it depends. If you have a really strong AMH, you still can. It tends to avoid cysts or breakthrough ovulation, so that's really helpful as well. And so that's why we use it. Yeah. Why would a fertility specialist suggest Lupron as the first step for an IVF protocol instead of birth control? Is one preferable over the other? 28 with PCOS and male factor? If you have PCOS, Lupron is 100% the wrong protocol for you. Women with PCOS tend to make an enormous number of eggs. If you're going to make an enormous number of eggs, you're going to have very high estrogen, and you're going to be at a very high risk of developing ovarian hyperstimulation syndrome. So how do we avoid that? We use the GnRH antagonist like orgalutran or cetrotide, and then you trigger with Lupron to release the eggs so that you don't hyperstimulate, because it more or less eliminates the chances of ovarian hyperstimulation syndrome. So taking Lupron ahead of time, if they're planning to use that as your anti-releasing medication to prevent ovulation, that's a mistake. That's a total mistake. I can see Katie saying that Darcy was amazing. Darcy is amazing. We love you, Darcy. So yeah, don't go on Lupron ahead of time. AMH is 70. Wow, Shannon, congratulations. If we were to do IVF and get enough eggs to store, I think you mean embryos, but okay, after the first transfer, are the next transfers included in the cost? Well, that depends on your center. Obviously, if you're doing it with us and you go for a guarantee program, yes. If you're going for our conventional program, no, we do have to charge for the additional embryo transfers. I think you'll find that pretty much with any center doing IVF. If there's a guarantee involved, then they'll cover the cost. And if there is no guarantee involved, then you would be paying extra. Great question. Beck, hit me with the next one, if there is a next one. There's always the next one, isn't there? Oh, I've got one I can see here. I'm curious what the chances are for a patient in Windsor to have their actual OB for delivery. 1 in 12. So there's 12 of us, so you have a 1 in 12 chance. What percentage of your OB patients do you end up delivering? Because some of them get C-sections, because some of them end up being induced on a night when I'm on call, because obviously many patients want their own doctor. probably somewhere between 15 to 20% would be a reasonable estimate. I've never actually calculated it, but I think that's a reasonable number. Beck, you can remove that question up there. I'll take an Instagram question. When going through menopause, are there any hormone replacements you should be taking? Oh, wow, great question. So menopause has risks and benefits to taking hormone replacement, which primarily focus on the use of progesterone. So if you're taking progesterone with the estrogen, your chances of developing breast cancer are higher, possibly ovarian cancer as well. So for the women with the uterus, it's questionable. If you're very young and you're doing it temporarily, it's probably okay. So you would take an estrogen, best is transdermal or a patch, and you should take vaginal progesterone, which is prometrium essentially. If you only have a uterus, you can take estrogen, which actually decreases your chances of breast cancer, as long as you have no heart disease, so no high blood pressure, diabetes, smoking, high cholesterol, strong family history of cardiovascular insult. It should be quite safe and actually protect you from many of those things. So that's a good approach to things. We are considering IVF. What is the impact of using an SSRI on sperm quality? There are some studies that have shown an impact. As long as his prolactin is not going too high, it normally doesn't have too strong an impact. And the studies that have been done are not great studies, so we don't know 100% for sure. And to the best of my knowledge, no one has looked at DNA fragmentation in SSRIs on men, which is really kind of, if there was going to be an impact, where it would come from. So we need more data is the answer to that question, but we don't get worried about it. You are great. Well, thank you. How far in advance should I start supplements before egg retrieval? And how many egg retrievals do you think I will need to get a euploid embryo at 44 with 1.4 AMH and 10 eggs? Well, 10 eggs is a lot at 44. So I would guess somewhere between 3 to 4 to get 1 or 2 euploid embryos. Depends on the center you're working with. Probably like 2 with us, 3 or 4 if it's somewhere that isn't quite as good. We have our amazing embryologist on our team, so we do a good job. Supplements, months. The sooner the better. But at 44, you also don't want to wait too long. So maybe 2 or 3 months before you do your IVF cycle would be reasonable. There was a study I did an Instagram post on last year showing that even up to a 6-month delay had no negative impact on your success rates, even when you were in an age category over 43. So it's actually a reasonable thing to consider. Beck, you had one I saw, so you can flash that back up again. FET starts mid-April. My last day one was mid-February. I had Trelstar injection March 8th and haven't had a menstrual cycle. No, that's actually what's supposed to happen from Trelstar, so that's normal, you're okay. Easy one. Would you be concerned with a 50% DQ alpha match? Okay. DQ alpha is this biological entity where you have these antigens and antibodies, and if you're a match, it supposedly very significantly increases your risk of failure. I started looking into this. It's actually probably worth a fact or fiction. The reality is no one knows for sure if this actually impacts things because there are studies that say it does and studies that say it doesn't. The jury is out. Would I be concerned? Yes. Would it prevent me from trying once? No, if you had insurance or you were covered for your IVF somehow. Yes, if you weren't. So that can be a problem for sure, and would need to be carefully discussed and reviewed with you so that you know what you're getting yourself into. Backfire away. Oh, no question for Beck. Is there a place for someone to see fertility clinic success rates? Yes, Nicole, it depends on whether you're in Canada or in the US. In the US, they have SART, S-A-R-T, which you can access online, and it actually has the clinic names. Canada has Carter, and you can't figure out which clinic is which. So it's interesting. You can speak to the clinics. Virtually everybody will lie to you, so that's not very helpful. That's an issue. Is it true some clinics will turn away a patient if they think they won't be successful in order to keep their success rates higher? 100% yes. In particular, I have heard many stories of Ontario-funded patients being skipped on the wait list because of the fact that they don't want to reduce their success rates. And our program is further confused or difficult by the fact that when I spoke to the health services branch of the ministry and the Ontario Fertility Program, they want to recommend that the allocation of funding be based on success, which means a big program that gets a lot of funding, that gets loads of people, will actually lose their funding because their success rates are lower because more people are going there. The small program that can cherry pick people and doesn't have as many is going to get more funding. So it's going to like kind of even out the playing field eventually, but not based on anything reasonable. It's just skewed data. So not particularly helpful for sure. But yes, that is true. Great question. And I apologize on behalf of everyone in fertility. Hi, Dr. V. Day 5 of stims. Before retrieval, is it important to reduce your water intake and replace the Gatorade coconut water? I've cut my water intake by half, but I'm so thirsty all the time. No, 100% no. Drink as much water as you want, but if you're hyperstimming, the Gatorade comes after the retrieval, not before. And please make sure you're getting a Lupron trigger. So don't reduce your water intake. If you're getting lots and lots of follicles, you're actually draining fluid out of your bloodstream to support the follicular growth and development. Plus, you may be getting what's called third spacing, which is that some of the fluid's actually collecting in your belly as the vessels in your body become leakier than normal. This is part of IVF and especially part of ovarian hyperstimulation syndrome. If that's the case, failing to take water will further dehydrate you, which can actually throw you into multi-system organ failure, kidney failure, real problems. So do not reduce your water intake. And you also don't want to be pounding back high sugar Gatorade yet. So keep up with your water, some healthy drinks, milk, juice, so on. And definitely don't hesitate. And if you're thirsty, you're dry. So make sure you're keeping up with your water intake. I've got one here, Beck. Give me a chance. Doctor, I have low estrogen. My OBGYN prescription hormone pills called April 21st. Prescribed hormone pills called a pre-21, my apologies, which I started before my IVF procedure. What do you think about a pre-21? A pre-21 is perfectly fine. There's nothing wrong with that. And that's a perfectly fine pill. If you have low estrogen, the only problem is you got to make sure you don't have weak ovaries. If you do have weak ovaries, going on the birth control pill is not a good idea before your IVF procedure. Yeah. Okay, Beck, go for it. If I froze my eggs and over half of the eggs were immature, is that a sign that possibly all of the eggs were of poor quality? Kate, it depends so much on when they triggered you. So there's always going to be some eggs that are mature, some that are not. What we've turned to now in cases like yours is the duostim protocol. So we don't retrieve those like small, medium-sized ones. We just leave them and then we wait 5 days, restart your stim, and then go back and retrieve them a few days later. And you get usually very good egg quality, very good outcomes without having to retrieve those eggs and then find out, oh, they were immature. You leave them, they'll grow, you go back and do another egg retrieval. So that's actually a great approach to things and works really, really well. It's not cheap because we actually have to duplicate everything we do: time, equipment, anesthetic, needles, media, blah, 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 ICSI equipment, all of that stuff. But we reduce our second cycle by over 37% in order to make it more affordable for patients, because many of those patients need the help. And we want to help. We don't do this for the money. We're doing it to help people. So, we try and make it as inexpensive as possible. So our duostim is actually much cheaper than doing just 2 cycles of IVF in a row. I'll take an Instagram. My first IVF ISC, I'm assuming that's ICSI, was successful 2 years ago. I would like to go for a second child, but I'm worried regarding my husband's sperm quality. It could get worse year by year. I'm in Dominican Republic. Great question. It can get worse, but there's lots of steps you can take to improve sperm quality. Healthy diet, exercise, weight loss, keep the testicles cool, ejaculate every 2 days, loads and loads of fertility vitamins, no smoking, no drinking, no marijuana or any other drug use. And then there are devices we can use and techniques. 2 sperm samples in the same day, 3 hours apart. Second sperm sample will have much lower sperm DNA fragmentation, improve your success rates. The Zymo device that we use, which processes the sperm and eliminates 90% of the sperm with high DNA frag. So there's lots of things you can do to try and improve your chances. Beck will do a few more questions. Hi, Dr. Victory. If you are supposed to take Cetrotide on the day of your trigger shot, how many hours? Oh, it doesn't matter. You can take Cetrotide anytime before your trigger shot. Most people space it out by several hours, maybe 2 or 3, but it actually doesn't make a difference. It's not going to prevent the trigger shock from working, so that's fine. Instagram, how many days should one stim for in the luteal phase? Day 13 of stim, 1 follicle at 29 and 2 below 15. Back for scan on day 16. Wow. Okay, I don't do that, and that's a follicular phase stim, it sounds like. So if you're in a follicular phase stim, we've reviewed this on the show before as well, stimulation should not exceed 12 days because your egg quality starts to decrease and your success rate drops dramatically. If you're in a luteal phase stim, so you did your follicular, you retrieved your eggs, you're now following, they're usually ready within 3 to 5 days, sometimes longer, but most people do not need 13 or 15 or 16 days. I would cancel that cycle if your drugs are covered. It does not make sense to continue. You will not get good egg quality from that. Sorry. Do you recommend any different treatment for methyl tetrahydrofolate reductase enzyme homozygous? Heparin for sure, and then you want the special folic acid, which is made specifically for patients. However, the studies actually don't support that, but the naturopaths do. I would definitely recommend you contact Jennifer Strong, our naturopath, and discuss it with her. She can discuss that with you, Jen, and advises patients on it. But you do need heparin, even though you don't have a coagulopathy. Patients with MTHFR need it. So that's something we do use. Yeah. Dr. V, you're the best. I'm not the best. I just try hard to help everybody. Thank you for taking the time to do these facts or fictions, and thank you for being such a great hands-on doc. My pleasure. I'm definitely not the best, just love doing what I do. Low sperm morphology. What is a healthy range for sperm morphology? Would recommend IVF over IUI. Wow, okay, let's start that. So sperm morphology using the strict criteria, which is very specific criteria, is 4%. Personally, I think that's insane, but that's the World Health Organization for you. These are the same guys that didn't tell us about coronavirus. So 4% is what they claim is reasonable. Would I recommend IVF over IUI? If you're less than 4%, you need IVF for sure. I would argue even less than 10%, you probably do. Does low sperm morphology increase the chances of birth defects? No, because abnormal sperm don't actually tend to bind to the egg. Doc, you're the best. I'm not. Thanks for doing these. You're welcome. Beck, go ahead. A couple more, and then we got to wind it up. I'm all scruffy, by the way, because I haven't shaved because I've been working nonstop from last night. Oh, Beck, you don't have one, or do you have one? I'm going to assume that you don't because there's nothing on the screen. My ovaries were removed when I did my fibroid surgery. I have a dermoid cyst which affected my ovaries. I am so sorry. You can use donor egg. and that's still an option for you, or if you have a family member that's possible, there's definitely options for you, Audrey, so reach out and we can help you. Is the Zymo technique used for all IVF protocols? No, because the sperm has to be able to swim through the membrane in order to get to the other side. So if you have very poor motility in your sperm, you can't use Zymo. It doesn't work well. Yeah, so that's important. Oh, the yellow car. Good question. I've got you the yellow car. Good eye, Krista. The yellow and the red fell off the wall. So they're going up shortly when I figure out how to stick these guys up there and have 2 minutes of free time to do it. So it'll take a little while, but I haven't done it yet. It'll come up in the near future. Maybe this weekend. Somebody give me 5 minutes of time and I'll get some glue. Okay. Oh, from that lady I just responded to. Thank you, doctor. You're giving me hope. Audrey, there's loads of options for you. There's donor egg. If you have a family member, we can use their eggs, a younger sister or an older sister, depending on your age. There's donors. As long as you've still got your uterus, there's no reason why you can't get pregnant and have a baby. Is a saline infusion sonohysterogram as effective as the surgery? So that's probably the wrong question to ask. The SIS shows you if it's there. The surgery lets you see if it's there and remove it if you have the right instrument or equipment. So no, it's not the same. I can't remove a polyp with an SIS, but you can with the surgery. Excuse me. Oh, have an IUI coming up. Wondering if there are any supplements I should take on top of the prescription meds. I answered that earlier, Anne. It depends on why you're having the IUI. So just flip back to the start of the show. But there's vitamins. There are supplements. It depends on your diagnosis, PCO or endo or just natural. So we did answer that question. Just watch the start of the show. Do I suggest DHEA and CoQ10 to improve egg quality? DHEA definitely does not improve egg quality. They've actually looked at that. There are no studies supporting an increase in even live birth, let alone egg quality. CoQ10 supposedly does. Technically, you need to take it for more than 6 months. If you find a fertility patient willing to wait 6 months, send them my way. It's hard to find them. Most people are very anxious and want it to happen yesterday. Okay, Live, Love, Fearless. I love it. Nice name. Husband had testicular cancer. Oh, I'm so sorry. And 25 radiation sessions. Okay. Frozen sperm prior, was sterile. Now count is 1.6 million. Is there a risk using fresh sperm for IVF since they had radiation exposure? There's a risk, but realistically, probably not, because keep in mind that women are born with all the eggs you ever have, but we make new sperm every 3 months, roughly, kind of 10 to 12 weeks. So there's probably no risk because whatever he's producing is being produced fresh. Now, yes, there are some chances that there's an impact from testicular function and so on. And depending on how long it's been since then, it should be okay. You would definitely get a benefit from using non-treated. Treatment was in March. Oh, you gotta wait a long time for that. So I would say minimum like 3 to 6 months. Oh, March, April of 2020. Nope, that would be fine. You'd be okay either way now. You're pretty much in the clear. If you want to be extra cautious, use the frozen stuff. It depends on how many vials they froze it into. If they just did one, you know, that's a little bit more sketchy, but if they froze it into several, yeah, just use one of them now. You'll still have multiple left, plus he's still able to do it. Bird Bash, how do we get a consult with you if we are in the US? Contact info@drvictory.com. They will set it up. We only charge 150 bucks Canadian, which is like 20 cents US, I think. No, it's about 110 or 115 US. And I spend about an hour with you, and we go over everything and see how we can help. And we don't try to push you towards us. Actually, especially these days, just help patients with colleagues I know in the US who are good and working at good centers. So if we can get you to them, we do. If we can just advise you, we do. Whatever works best for you guys. Okay, Beck, last question. You got something for me, or are we done? I think we are done. Cool. All right, guys. Thank you so much for an amazing show. Really glad to be able to help you guys out. Love doing this show. Sorry for my scruffy appearance. If you like the beard, let me know. Throw up some hearts and I'll convince my wife to let me keep it, which will last all of 5 seconds if I'm lucky. And we will go from there. You guys have a wonderful, wonderful evening. Stay safe. Get your vaccines. A 2-month delay in your fertility is meaningless, but it could save your life and, more importantly, the lives of many others. So don't hesitate. Get your vaccines. Stay safe in the meantime. Wear your mask. Wear your protection. And we'll see you again next week on Fertility Fact or Fiction. Special thanks to Rebecca, who sat in for Tarek. And I do need to ask our whole community to say some prayers for Tarek to make sure he gets better soon. We want him back by next week. Have a great night, guys. You take care. Bye now.